Welcome to this explainer. Today, we're tearing into a concept I like to call the airway that can't uncurl. We're going to strip bronchiectasis and cystic fibrosis right down to their absolute first principles, because when you look at permanent airway damage through the lens of foundational mechanics, I promise you, the whole clinical picture suddenly makes complete sense, and even the most recent treatment guidelines fall perfectly into place.
Okay, let's dive right into this. Picture yourself standing at the bedside. You've got your stethoscope on a patient's chest, and you hear it, those coarse, wet-sounding crackles. Now, what happens if you ask that patient to just cough? It sounds basic, right? But that single, simple bedside maneuver is actually one of the highest yield, yet somehow most underused diagnostic tests we have. Skipping it is honestly one of the most common reasons this disease gets misdiagnosed in the first place.
Here's what happens. The crackles change. Sometimes they literally clear entirely, only to kind of slowly creep back a few minutes later. And this is key. Unlike the fixed, structural crackles you hear in, say, pulmonary fibrosis, these crackles are completely mobile. They're generated by secretions pooling up in dilated airways that just can't clear themselves. So when the patient coughs, they're physically redistributing that mobile material. It perfectly sets up our whole understanding of the airway mechanics we're unpacking today.
So, here's our roadmap for this explainer. First, we'll hit the vicious vortex, then the OK chaps causes, followed by the big 2025 ERS Guideline shifts. After that, we'll break down cystic fibrosis mechanics and wrap up with the infertility contrast.
All right, moving right along to Section 1, the vicious vortex. Let's look at this cycle of airway damage. Let's ground ourselves with the definition. Bronchiectasis is the permanent, irreversible, and abnormal dilatation of the bronchi. I really want you to anchor onto that word, permanent. This isn't just a one-off infection, like your standard bout of bronchitis that clears up after a week. No, we're talking about an ongoing, structural change to the airway wall itself. But, why does it actually become permanent?
Well, this brilliantly illustrates exactly why. It's an inescapable, self-perpetuating trap we call the vicious vortex. It kicks off with step 1, some initial insult, maybe a severe infection that damages the airway's structural integrity and trashes its cilia, which leads to step 2. Those damaged airways now do a terrible job clearing mucus, leaving it totally stagnant. Step 3, that stagnant mucus is basically an all-you-can-eat buffet for bacteria, leading to colonization. Step 4, this chronic infection drives relentless inflammation. And finally, step 5, that inflammation causes even more structural damage, making mucus clearance even worse. It's wild, right? Every single turn of this wheel actively worsens the next, cementing that permanent structural change.
So let's move to Section 2, the OK chaps causes. Finding the trigger here changes everything about how we manage this. To track down that trigger, we use a super practical mnemonic you really need to know cold. OK chaps. That's obstruction of the bronchus, Cartaginer syndrome, cystic fibrosis, hypogammaglobulinemia, allergic bronchopulmonary aspergillosis, pneumonia or severe childhood infections, and finally, Sjogren's or other connective tissue diseases. Honestly, if you have a patient with a recurrent cough dating back to childhood, your instinct should immediately jump to cystic fibrosis, hypogammaglobulinemia, or previous childhood pneumonia. That's 3 totally different mechanisms all converging on the exact same presentation.
Let's zoom in on one of those causes in particular, Cartaginer syndrome. This is an autosomal recessive disorder driven by primary ciliary dyskinesia. It gives you this classic triad of dextrocardia, chronic sinusitis, and bronchiectasis. And here is a massive clinical pearl for you. If a patient with bronchiectasis also mentions they're dealing with infertility, you have got to actively examine their chest for dextrocardia. Think about it. The exact same ciliary defect ruining their airways is also tanking their sperm motility or fallopian tube function. Finding that dextrocardia basically ties the whole clinical mystery together with a neat little bow.
Now, as that vicious vortex spins year after year, it eventually crosses a dangerous threshold and triggers some severe complications. We're talking massive hemoptysis from bronchial artery erosion, nasty recurrent infections, lung abscesses, or even cor pulmonale from chronic hypoxic vasoconstriction. But I really want to highlight secondary systemic AA amyloid doses. If your long-standing bronchiectasis patient suddenly shows up with nephrotic syndrome, that's your huge red flag right there. Chronic suppurative disease drives amyloid deposition over the years, and it'll march straight down to wreck the kidneys.
All right, let's shift gears to Section 3, the 2025 ERS Guidelines shifts. These are some genuinely important new updates.
Now, what's really fascinating about this slide is the remarkably strong wording they used. The December 2025 guidelines explicitly recommend against using dornase alfa in ordinary non-CF bronchiectasis. Now, dornase alfa is an absolute foundational therapy for cystic fibrosis, right? But in non-CF bronchiectasis, not only does it not help, it might actually cause harm. This perfectly captures why identifying the underlying cause is so absolutely crucial. A drug that is a literal lifesaver in one airway disease can totally backfire in a closely related one, simply because the underlying biology of the secretions is different.
These guidelines also dropped some massive refinements regarding antibiotic use. Long-term macrolides, they are definitely not the default for everyone anymore. Now, they're strictly reserved for patients suffering 2 or more exacerbations per year or those who've had a severe hospitalized exacerbation. Plus, before you even think about writing that prescription, you mandate an exclusion of unrecognized non-tuberculous mycobacterial or NTM infection. Why? Because macrolides can make NTM so much harder to treat. You also need a baseline ECG to check their QT interval, a hearing screen, and a formal review at 6 to 12 months. No more just leaving patients on these meds forever.
If you had to distill the entire philosophy of the 2025 ERS Guidelines into a single phrase, it's this: doing the simple things well. That means prioritizing laser-accurate cause identification, optimizing everyday airway clearance, and using appropriately targeted pharmacotherapy, rather than just reflexively escalating to heavier treatments.
Okay, moving into Section 4, cystic fibrosis mechanics. We're looking at how a single gene defect causes all of this.
It all traces back to right here, the CFTR gene. This gene encodes a critical chloride channel. When it's defective, you get abnormal CAMP-regulated chloride transport across your epithelial cells. And the downstream fallout from that, you get decreased chloride secretion paired up with a spike in sodium and water reabsorption. The end result is thick, dehydrated, stubbornly sticky mucus absolutely everywhere the CFTR protein lives. Airways, pancreatic ducts, the biliary tree, sweat glands, you name it. A single molecular misfire creates this sludge that just blocks the whole shebang. It's honestly mind-blowing how one tiny cellular glitch triggers such a massive multi-system breakdown.
So to diagnose it, we look straight at the sweat glands. Because that channel is broken, chloride can't be reabsorbed from the sweat, which leaves the patient with highly salty sweat. To lock in the diagnosis, you need 2 separate sweat chloride measurements coming in above this magic number, 60 millimoles per liter.
But, hey, you've got to watch out for false positives. Conditions like adrenal insufficiency, hypothyroidism, panhypopituitarism, glycogen storage diseases, mucopolysaccharidosis, and even really severe atopic dermatitis can bump up that sweat chloride without the patient actually having CF. So always keep those in the back of your mind if the clinical picture just isn't quite adding up.
And because that thick mucus is a whole body problem, you've got to stay on high alert for systemic complications. For instance, if a CF patient rolls in with acute right iliac fossa pain, do not just blindly jump to appendicitis. You need to be thinking specifically about meconium ileus equivalent, otherwise known as distal intestinal obstruction syndrome. It happens when all that thick and spicitated fecal material literally blocks up the distal gut. Luckily, we can usually manage this medically with laxatives, enemas, and aggressive rehydration before we have to resort to surgery.
When it comes to management, we're relying on chest physiotherapy, antibiotics, pancreatic enzymes, and yes, dornase alfa. Now remember earlier when the new ERS guidelines explicitly said not to use this in non-CF bronchiectasis? Well, it works beautifully here because it targets the extracellular DNA left over from neutrophil breakdown, which is exactly what makes CF secretions so notoriously thick. But guys, the absolute biggest game changer in the history of CF treatment? Trikafta. It's a triple modulator therapy, elexacaftor, tezacaftor, and ivacaftor, for patients with the F508del mutation. It is literally breathtaking technology. It corrects the CFTR protein folding while simultaneously boosting the channel function, leading to just massive real-world improvements for these patients.
And that brings us to our final part, Section 5, the infertility contrast. Let's compare these mechanisms side by side.
So, the crucial point I want to leave you with is this. Both of these diseases cause male infertility, but they do it through entirely different pathways. In cystic fibrosis, those ultra-thick secretions in utero cause the congenital absence of the vas deferens. It is a purely structural anatomical roadblock. The sperm themselves are actually completely normal and motile. But flip over to cardiogenic syndrome, and the vas deferens is structurally fine. The problem there is completely functional. The ciliary defect means the sperm are immotile. It's 2 entirely different molecular failures that ultimately hand you the exact same clinical finding. Which naturally leads us to this final thought. Infertility isn't a diagnosis. Honestly, neither is a cough. When you're staring down a clinical presentation, you have to ask yourself, are you just treating this symptom, or do you truly understand the hidden mechanism driving it? Whether it's the inescapable vicious vortex of bronchiectasis or a single broken chloride channel in cystic fibrosis, starting from first principles is the absolute only way to ensure you're actually treating the disease. Thank you so much for joining me on this explainer. Keep asking why and always, always keep looking for the mechanism.